credit or offer credits for docs, nurses, social workers, clinical psychologists, and likely. Help yourself, grab your food and eat. I don't think any of the presenters will mind. And we will get started. Dr. Wolf.
A couple more people walking in the door now, but I'll go ahead and get started. I don't like penalizing the people who are on time, and I know we have several sites that have several people who are joining us through video conferencing. So I'm Dr. Kari Wolf. I'm the chair of psychiatry at SIU School of Medicine, and I'm the PI on this grant to do educational series talks to places in central and downstate Illinois to really look at appropriate opioid prescribing, alternatives to opioid, things that we can do as providers to really address the opioid crisis. So today is the first of a series of talks that we will be providing. We are touring around the state, but we're doing this video conferencing to everywhere in the state. So we came to you today, but you are welcome to participate in future talks through the Zoom technology. So you're all welcome to do that, and I'm sure Laura will talk with you about how you can get involved in that. It's my pleasure today. I have three very talented psychiatry residents who all have some specialized interest and expertise in substance use disorders and opioids. And so the four of us, primarily them, are going to be presenting three TED-style talks. So instead of a PowerPoint where we are out there droning on with slides, we're actually going to do TED-style talks, like TED videos. So I have Dr. Shaw with me, who's going to lead us off, then Dr. Abbott and Dr. Maloch will round us out, and then we'll have time for some questions and answers. For those of you on Zoom, I am going to be watching the chat technology, so if you want to send questions that way, we'll be sure to get your questions answered as we go through. So with that, let me turn it over to Dr. Shaw.
Thank you, Dr. Wolf. Good afternoon, everyone. So today we're going to be talking about the opioid epidemic, and we're going to be targeting prescriber education. As we all are aware, our country is in the midst of a major public health epidemic. The Illinois Department of Human Services, the Division of Alcoholism and Substance Abuse, awarded a grant to SIU for the development and implementation of our rural opioid prescriber training program. And this is to train prescribers of opioids on the best practices and prescription guidelines for opioids in the 66 counties where the SIU School of Medicine region is. And this will be one of 6 presentations. So I'd like to start off with a case to highlight exactly what we're facing. So we had this guy, 25-year-old, let's call him Mark. Mark grew up in a really nice town, and he went to college, he got a nice job as a financial analyst, and he got married, 3 kids, and owns a really nice 4-bedroom home, 2 cars. Things were going great. He was living the American dream. And then one day, he's driving back from work, and he gets hit by another car. And he sustains many back injuries, and he's in a lot of pain. He gets physical therapy, but he's still having some pain. So he goes to his primary care doctor, where his primary care doctor prescribes him opioids. And he started on a very high dose of opioids, and he prescribed them indefinitely. So Mark trusts his doctor, and he takes these opioids, and he's pretty tired, he develops constipation, and he's able to go to work. And he takes this for about a year, and he goes back to his primary care doctor for a follow-up appointment. And at this time, he finds out that his primary care doctor is no longer there. He found out his primary care doctor lost the license for prescribing in the state. And this is for inappropriate prescribing of opioids. So the doctor that takes over Mark's care refuses to prescribe any opioids because he's scared of what's going on. So since Mark has been on opioids for about a year, he's developed a dependence and a tolerance. So he starts going to withdrawal because he's not getting these opioids. He's feeling miserable. He's in a lot of pain. He's feeling flu-like symptoms. He's able to go to a few ERs and get some pain medications temporarily. He goes around other doctors, is not able to find opioids, and then he asks a few friends for help, and they give him some pain meds. However, this is expensive, and he's running out of money. So he doesn't want to go to withdrawal again and feel miserable. and he asked a friend for help. And this friend comes over and brings a bag, and Mark was like, "What is this?" And it was heroin. Mark freaked out because he'd never done drugs before. He thought he couldn't do it to himself or his family. However, he felt like he had no other options, and he just wanted to feel normal. He didn't want to get high. He just wanted to feel normal and function, just like all of us here. So he tries the heroin, and it helps, and he doesn't go into withdrawal. However, his drug use came with consequences. He was arrested a few times, he lost his job, and his family wasn't too supportive of this, and they left him. And this guy lost almost everything. And one day, a DEA agent came to his house and said, "Look, we know you've been using heroin, and we can take you into federal prison, but we have this program at the Well Center in Jacksonville," back then when it was around. And they said, "You can get treatment right now, or we'll come back in 30 days, and we'll take you to federal prison." So how is it that a successful, family-oriented guy like Mark, with a good background, who never did drugs, become addicted and lose everything? Well, hopefully by the end of this presentation, we'll have some better answers. So let's break down opioids. What are opioids, and how do they work? Opioids are part of a drug class that includes heroin and synthetics like fentanyl, morphine. They act on opioid receptors on nerve cells in the body and brain. They have many uses. They can be used for cough suppression. They can be used for analgesia. However, they can also worsen pain and functioning. They can lead to dependence. They can be abused. They can even cause euphoria, and they can do more harm than good. Now, to highlight how significant this epidemic is, I'd like to go over some numbers. Right now, 11.2% of Americans have chronic pain. How many of these Americans are on opioids for a long-term basis? About 3 to 4%. How about heroin? How many people have a heroin use disorder? About 500,000. What's the economic burden of prescription opioid misuse? $78.5 billion. So that includes healthcare costs, lost productivity, addiction recovery, and criminal justice involvement. Now, right now, 21 to 29% of all patients on opioids that are prescribed for chronic pain abuse them. Yes, that's 21 to 29%. Now, how many of these people develop an opioid use disorder? About 8 to 12%. Now, right now, 4 to 6% of people that misuse prescription opioids, like Mark, will transition to heroin. Now, how about what percentage of all people who use heroin first misuse prescription opioids? 80%. And then every 25 minutes, a baby is born and will undergo opioid withdrawal. And as of February 2018, 115 Americans will die every single day from an opioid overdose. I don't know if you guys noticed, when I went over all these statistics, a lot of these involve prescription opioids. Prescription, as in prescribed by a prescriber. So it's our job to ensure that we're prescribing appropriately, responsibly, and safely. Well, how are we going to do this? Well, let's talk about prescription guidelines. Say you have a patient that comes in with pain, and you're considering starting opioids. What do we need to do? Well, first, we have to do a comprehensive assessment and documentation. You want to find out what kind of pain is the patient having. Is it neuropathic pain? Is it fibromyalgia pain? Is it musculoskeletal pain? Is it sickle cell pain? Is it inflammatory pain? Or is it a headache? And you want to screen for opioid abuse. You want to obtain a substance use history. Find out if they've used heroin before. See if they've used IV drugs. But also, you want to be careful when you're asking about this because it's a sensitive topic and not everyone's eager to divulge this. And we have different assessment scales, like the ORT, which is the opioid risk tool. We have the SOAP, which is screener opioid assessment for patients with pain. And then we want to utilize prescription monitoring programs. Does anyone here know about Illinois prescription monitoring? Okay. So as of January 2018, all prescribers who have a license to prescribe and a controlled substances agreement or controlled substances license are required to be registered in Illinois prescription monitoring. So when your patient on opioids comes in, you want to do random urine drug testing. And if your patient with chronic back pain comes in, you want to specify what kind of back pain is it. Is it degenerative disc disease? Establish a physical diagnosis. And then also assess for comorbid psychiatric conditions. A lot of these patients with pain will have conditions like depression. It's important to get them treated. Now, when your patient says, "Ow, my back hurts," and you're considering opioids, do a physical examination. Consider imaging. Ask your patient, how bad does it hurt? What can you do? Use basic scales like a 0 to 10 pain scale. And there's other scales that you can use that'll indicate pain or disability. There's the PEG scale, which is pain, enjoyment of life, interference, and general activities. And you want to stratify patients based on risk. And now it's important to set up goals. Ask them, what are we aiming to get with these opioids? Pain relief, functionality. Now that we've followed all these steps for prescribing opioids, are we ready to prescribe? Do we just hand them a script? Here you go? No. You need to do a comprehensive opioid agreement, and this is a robust agreement that needs to be followed by both parties. So this can include even discontinuation of the opioids and termination. We have to be careful. We don't want to abandon our patients. We want to get them home. There's a saying, start low and go slow. This refers to starting opioid therapy with low dosages and short-acting opioids. And you only want to give the absolute minimum quantity needed. Mark's physician didn't do that. There have been ER physicians after surgeries like laparoscopic cholecystectomy that will prescribe 60 tablets of opioids with 3 refills. That's not necessary. That can lead to addiction. Now, when we're looking at opioid dosing, there's low dose, which is 0 to 40 morphine milligram equivalents. There's moderate dose, which is 41 to 90 morphine milligram equivalents. And then there's high, which is above 91 morphine milligram equivalents. So who cares? Why are we talking about all this dosing and morphine milligram equivalents? Well, it's important because when you're at above 50 morphine milligram equivalents, the patients are twice as likely to overdose and die. And then when you get above 98 morphine milligram equivalents, the risk of overdose is really high. And studies have shown that at that dose, there's not much of a therapeutic benefit for patients. All right, so how do you calculate morphine milligram equivalents? Well, if you look at the handouts, there's a chart, a conversion chart. I think it might be on the back page of one of the handouts. And there you can find all the generic names of all the opioids. And if you look at the opioids and the dose that your patient is on, you're going to multiply it by the conversion factor. And then you're going to add up all of it to get the total morphine milligram equivalents. So let's work through a quick example. Say your patient is on hydrocodone, 10 milligrams twice a day. How many morphine milligram equivalents is that? So the conversion factor is 1.
Can you repeat?
Sure. So hydrocodone, 10 milligrams twice a day. So 20 milligrams, and that would be conversion factor is 1, so you multiply it, so 20 morphine milligram equivalents. How about methadone, 20 milligrams once a day? This one's a little different because methadone has different conversion factors for dosing. So I said 20 milligrams. So if you look at the chart, what's the conversion factor there? So how many morphine milligram equivalents would that be? Yep, you just multiply, so it's 80 morphine milligram equivalents. All right, so after you've tried opioids for certain patients, you've tried higher dosages, you're still struggling, you've tried like maybe a buprenorphine patch, and you're considering methadone, that can be used, but you want to only use it in FDA recommended dosages. And you want to monitor it carefully, maybe with an EKG, because methadone can prolong the QTC interval, and that can lead to cardiac arrhythmias and torsades. Now, it's our job to be an educator and advocate for our patients. We want to discuss adverse consequences and what are the effectiveness of starting short-acting and long-acting opioids with an emphasis on adverse consequences for long-acting opioids. A lot of this might seem like common sense and it might be redundant, but this is the key to saving lives by following these prescribing guidelines. So you want to ask your patients, how's it going? See if they have at least a 30% improvement in their pain or functional status improvement without consequences. And remember, don't start with long-acting opioids like extended release morphine, fentanyl patch. You want to save that for only severe intractable pain. And it's important that you do urine drug testing and prescription monitoring programs like our Illinois one for adherence, abuse, non-compliance. Now, it's our job to make sure we're not doing any negligent prescribing because this can lead to diversion And diversion can lead to abuse, overdose, death, and it can lead to a prescriber losing their license. Now, we want to watch out for side effects with opioids, like constipation. You want to manage them, and this can even include discontinuing opioids. Now, if your patient, say your patient's doing really well on the opioids and it's medically necessary, it's fine. You can continue them as long as there's appropriate monitoring. And then, again, stop opioids when there's no response, when there's bad consequences, and get them help. Send them to abuse. Send them to rehab when there's abuse. Now, there are some alternatives for opioids, and Dr. Abbott will talk about that. So now that we went over all the prescribing guidelines and all the statistics for opioid epidemic, I hope you guys took something away or strengthened your knowledge. And for those of you that are wondering what happened to Mark is one of the fortunate few. He went to rehab at the Jacksonville Center in Wells Rehab, and he got recovery, and he obtained a master's degree, and now he's advocating for all patients with opioid use disorders. And I see him speak, he's pretty motivated, but he's one of the few that made it. Most people will continue to become addicted, a lot of people will overdose and die, but I'm hoping that if we start to target this opioid crisis by utilizing these prescribing guidelines and educating our patients and diagnosing and treating these opioid use disorders, we can start to make a difference. Now I'm going to hand it off to Dr. Abbott, who's going to talk about alternatives to opioids.
If I could just ask, as best you can, speak towards the podium, that they're hearing it better when you're kind of speaking to the children. Okay, thank you.
Okay, pleasant good afternoon to you all. Thank you for attending today's talk. Thank you, Dr. Shah, for paving the way so that I can talk about safe alternatives to opioids. And just to give a disclosure, my aim here today is not to stop people from prescribing opioids. Actually, none of our aims is to stop prescribing opioids, but to do it safely and responsibly, like Dr. Shah said. And for those of you who are non-prescribers here, to also be able to make suggestions when you see patients are possibly being overprescribed opioids as well. So to start off, I just want to highlight a statistic from the CDC, which said that in 2015, every one of you here and every other American was able to be prescribed enough opioids to last them 3 weeks round the clock, just because of the amount of opioid that was prescribed in that year. And I think that's pretty astonishing, and that pretty much sets us up to realize how big of a problem this is and why we are having this talk today. So according to the CDC guidelines that were put out in 2016, what we found is that opioids are not the best tool to treat chronic non-cancer pain. And what they've recommended currently is that non-opioid treatment should be used as first line. So what are these non-opioid treatments that we are talking about? So this could be considered from a pharmacological standpoint in terms of medications and also interventions, which also utilize medications and anesthetics, or it could be considered from a therapy-based standpoint. So I'd like to start off by talking about the therapy-based standpoint. And essentially, when we're talking about therapy, we're talking about psychological therapy, as well as physical therapy exercises. And what is very interesting is that now with these CDC recommendations, we're now moving into what's called the biopsychosocial model of managing pain. And if any of you are involved in psychiatry, you know that we stress heavily on a biopsychosocial model for managing psychiatric patients because it's holistic and you target the whole patient. So pretty much a similar concern with managing pain. It's not just about getting a magic pill that stops everything, but getting the patient engaged and getting the patient involved in their care. So when we talk about things like therapy, we talk about cognitive behavior therapy, which is a psychological technique where patients are essentially seeing a therapist to help them deal with a lot of psychological aspects of pain. So like Dr. Shah mentioned, a lot of patients with chronic pain, they do have comorbid depression and anxiety. So going to CBT not only targets those comorbidities, but it also helps patients deal with the stress of the pain, deal with the preoccupation of the pain, and also helps them in terms of motivation to do some of the exercise therapies that I will mention, and some of the mindfulness techniques that you guys hear about, deep breathing, deep relaxation, those sorts of things are also stressed in CBT. And studies have found that CBT is very helpful for helping manage chronic pain. Not as a standalone therapy, but alongside medications has proven quite a bit of benefit. Other techniques in the realm of exercise therapy include more formal techniques like physical therapy. Do we have any therapists here? Okay, no. But physical therapy and occupational therapy are some of the more formal therapies that are well utilized and could be utilized some more in terms of treating chronic pain, especially chronic lower back pain and osteoarthritis. For patients who have limited access, either because of availability in their local area or in terms of accessibility because of insurance coverage or being able to afford, we could also recommend simple exercise techniques, simple stretching exercises. We could give handouts to patients, and also things like, which may not be from a physical therapist, for instance, but yoga therapy and Tai Chi, which are now crossing over into the complementary and alternative medicine. Those techniques have also been found to be helpful for pain. So why are these techniques helpful? Well, especially yoga, it emphasizes stretching, movement of the body. So if you imagine somebody has osteoarthritis and they haven't been moving their arm for a long time, that starts to be very restricted and causing a lot more pain. So getting people to move more, stretch, improve their posture, do strengthening exercises, which is targeted in these therapies, have proven to be very effective for managing pain. Other techniques that can be utilized along in the realm of complementary and alternative medicine include chiropractic treatment. I have never had chiropractic treatment myself, but my understanding of it is that it's pretty much based on spinal manipulation. So when we talk about patients, especially with chronic back pain, it is interesting that studies have shown that there is about a small to moderate effect in terms of treating the pain. And this sometimes can be used as standalone therapy along with medications. And essentially, coverage for chiropractic treatment may be a limiting factor, but there are some Medicare plans that would cover if it's to target subluxation of a vertebrae. So when a vertebrae is out of place, trying to realign that, it might be covered under that treatment. Other treatments include acupuncture. Has anybody here had acupuncture before? Neither have I. But the studies are now showing that acupuncture would be a safe alternative to opioid therapy. You might have some discomfort because of superficial placement of needles, but for patients with fibromyalgia and also chronic back pain, there has been shown some benefit as well. Again, coverage is an issue. There is not much coverage for acupuncture through most of the Medicare plans. One physician was quoted as saying that somebody might pay about $4 to $5 for a generic opioid compared to $70 for acupuncture. So it is there and it can be used, but there is an increased push towards getting more coverage so that we could recommend these to our patients and that it may be a practical recommendation. Other techniques that may be utilized include hypnosis even. And even hypnosis in terms of getting the patient to deal with stress has been shown to help with chronic pain. Again, this is not necessarily covered by Medicare, but these are techniques that are being studied more, and there is a lobbying towards getting more coverage for these. In terms of some of the pharmacological interventions that can be used, our basic acetaminophen has been recommended as first-line treatment for some of our chronic pain, like chronic back pain, acetaminophen, and also osteoarthritis, in terms of treating patients for chronic pain. In terms of the dosing, there are people that have a lot of concern about acetaminophen. We know that there is a risk of liver damage, and you could use acetaminophen safely up to 3 to 4 grams daily. A lot of patients don't know that, and they would use 500 milligrams in the morning, 500 milligrams at night, because they're concerned for damage to their liver. Of course, if a patient is a chronic alcoholic or if a patient has history of liver damage, you would want to reduce that to about 2 grams in a day to avoid them developing what we call hepatotoxicity. Another simple agent over the counter which can be considered for pain management are our what we call non-selective anti-inflammatory drugs such as ibuprofen. These can be used, and there are more that are selective like naproxen, meloxicam are also examples. And unfortunately, these drugs also have their side effects. A lot of us may know that gastrointestinal bleed would be a side effect of having NSAIDs, and also there is cardiovascular risk and also risk for kidney failure. So we're not saying that these are absolutely safe. We're recognizing that there are risks. But what the studies are showing is that the long-term risk of treating a patient with an opioid is showing to be much worse than some of the risk factors associated with these medications that I've mentioned thus far. Other medications that can be used include medications for seizures, so our anti-epileptics like carbamazepine or gabapentin is one such medication. Pregabalin, which the trade name is Lyrica, those medications have also been shown to help what we call neuropathic pain, so pain which results from damage to our nerves. So a lot of these medications are being used in practice currently. However, we'd like to recommend that they should not be used second line after starting an opioid, but try that medication off the bat and see if the patient gets benefit from it. And of course, some of the side effects to look out for include sedation and also having trouble with gait disturbance. Increased risk of falls should be something that patients should be made aware of. Another area that we found to be helpful is antidepressants. So medications that we use to treat depression and anxiety, pretty much because we are psychiatry residents, have been found to be helpful, especially for neuropathic pain, again, that nerve pain. Some of these antidepressants are venlafaxine and duloxetine. These medications have been shown to be very helpful. They're in the class of serotonin, norepinephrine reuptake inhibitors. And duloxetine is better tolerated than venlafaxine most times. Venlafaxine could also increase patients' blood pressure, so we have to be aware of that. Tricyclic acids like amitriptyline and nortriptyline have also been shown to be helpful, but these are off-label use for neuropathic pain. And they're recommended to be used at bedtime because they could also cause sleepiness, sedation, and also some trouble with gait, risk of falls as well. So that leaves me with talking about interventions that can be used for treating chronic pain as an alternative to starting opioids off the bat. Some of these interventions can be done right in a physician's office, such as an intra-articular injection, so injection of the knee or shoulder, for instance, in somebody who has osteoarthritis. Usually these injections consist of steroid and anesthetic like lidocaine or bupivacaine. Other techniques which may require referral to a pain specialist include trigger point injections. And basically a trigger point is an area of muscle tenderness, so it's like a knot of fibers that is just very painful. And just the injection of that area with or without any medication has shown to improve some of that pain. Other areas in terms of pain specialty management include doing blocks, so like a sympathetic nerve block for chronic back pain and chronic stomach pain as well, plexus block for somebody who has chronic neuropathic pain, and also we also recommend epidural injections, and again that is done in the pain clinic. Basically steroids and anesthetics are injected, and that provides about a 3-month window of pain relief. More long-term therapy intervention, is radiofrequency ablation technique. I recently only learned about this when I shadowed a physiatrist, and essentially they use some chemicals to ablate a nerve in the facet joint, and that provides pain control for about 1 year. So these are a lot of techniques that I've mentioned, and I have by no means exhausted the list. There are other techniques which are being studied, like transcutaneous electrical nerve stimulation. Unfortunately, I haven't gotten much data saying that that is very effective, but those are some of the things in the work. So essentially, to summarize, what I'm trying to show is that we don't need to treat patients right off the bat with opioid medication. We have a lot of different options, and making sure we make informed choices and educating our patients. And for you now to be equipped with saying, hey, I think we should probably try something else. So thank you, and I will let Dr. Baloch talk further about patients with opioids and opioid use disorder. Thank you.
All right, well, thank you, Dr. Abbott. I'm curious, from the audience, how many of you have experienced patients with opioid overdoses in the community? Okay, not too many, maybe a few of you. Any deaths in this area? Okay, so pretty fortunate out here, but if you come up north to Chicago, you'll see a lot more of that. And I'm going to touch a little bit more on the opioid use disorder part and opioid overdose deaths. With the numbers that Dr. Shaw talked about, I mean, it's quite astonishing how many people are using these pain medications. Mississippi Attorney General Mike Moore described it pretty well. He's like, it's a 737 crashing every single day and killing everyone on board. That's over 100 people a day. So if that was happening in the skies, we would shut the airports down until we figured out what was going on. So that's kind of what we need to do with this as well. We need to figure out why are all these people dying from our opioid pain medications. I think the first thing we really need to look at is preventing the dependence on these medications. And so how do we do that? Well, more appropriate prescribing like Dr. Shaw and Dr. Abbott talked about. And then we'll touch on those people who are already dependent. What do we do for them? Well, we want to make sure that access to care, to rehab services is easier to come by and more affordable than buying prescription pills off the street or buying heroin, fentanyl, things like that. As healthcare workers, I mean, we came into the field to educate, influence, and take care of our patients. So we need to live up to that and help them out the best we can. As a psychiatrist, I don't prescribe too many pain medications. And so it's funny that I'm up here talking about this, but we often inherit a lot of these patients who come to us on a whole lot of pain medications, muscle relaxants, and benzodiazepines. And you're trying to figure out, well, what was going on? How can I get these people off of this? And oftentimes these patients are reluctant to do that. And the astonishing thing is most of these patients come to us after being fired by their primary care doctors or their pain doctors because they violated one of the controlled substance agreements, similar to what Dr. Shaw talked about. You know, we should set these up and make sure our patients abide by them. But like he said, we can't just abandon them after they've slipped up once. So we really need to work with them and help them instead of firing them in those cases. I mean, as a psychiatrist, we see addiction quite often. And so we know addiction is a disease and it's not often a choice. And so these individuals need the help that we can offer them. It's often frightening for us doctors and other healthcare providers to give things to our patients that may be harmful to them. We're also worried about sanctions from the state, people losing their licenses and things like that. So we ought to keep all of that in mind, but at the end of the day, we need to remember we need to help our patients, and we should continue those medications in the patients who need it, try tapering them instead of cutting them off cold turkey. Let's step back to 1996, many years before I went to med school. But in 1996, there was the introduction of a fifth vital sign. How many people here remember the introduction of that? Okay, so that fifth vital sign was pain. And now any hospital you go into, any clinic you go into, you got those cute little smiley faces on the wall, rate my pain 0 to 10. And so I think that created this idea that we're going to completely get rid of pain, and our patients expected 0 pain on that scale. And I think that may have been where we were slipping up as well. We needed to educate them that we're trying to control your pain. We may not be able to completely resolve all of your pain. And at the same time, we also had these pharmaceutical companies come out and tell us that these new pain medications are less addictive. And so we felt more confident giving them to our patients, saying that we're making a difference in their lives. and they're not addictive, so we can keep these going for a while. And now we know better that these are not unaddictive. These are pretty addictive medications and they have risks. So we're learning as we're going. And, as healthcare workers, that's the goal. We want to help our patients get better and not suffer. So the unfortunate thing with that is prescribing is just so easy. It's easier to write out a script and hand it to your patient. Here, go get this filled. It'll get rid of your pain in the next hour and you'll be comfortable for a while. Psychiatrists see that all the time. Xanax or alprazolam, so commonly given for anxiety. And we would like to refer our patients to CBT, other psychotherapies, but patients find that pretty difficult. Who wants to sit through an hour of really emotional turmoil over their issues going on at home when they can just take that alprazolam and get better? Very similar to these pain medications where yoga, physical therapy, occupational therapy, they're exhausting. And so if that hydrocodone can get them up and functioning, getting them to work, it's not surprising that they would choose that. So we need to educate them about these differences and these concerns. Now, we need to remember that with these opioid pain medications, tolerance develops really quick. After 2 or 3 days of continuous opioid use, these patients develop tolerance. And after about a 10-day supply, or those patients who were given a 10-day supply, 1 in 5 patients becomes a long-term user. So it's not surprising someone like Dr. Shah's patient would become dependent on these medications if he was given months worth. The National Safety Council released some numbers which were quite astonishing to me. Over 99% of providers give more than the recommended 3-day amount of opioid pain medications, and a fourth of providers are given more than a month's worth of pain medications. And what we often see is, according to these numbers, which is pretty true, 90% of our patients who have overdosed on a pain medication were given that same pain medication script when they returned back to the clinic because of ongoing pain. So we didn't really talk to them about different options or anything. We just gave them another script, and that was pretty unfortunate. Now, it's hard for a lot of us to manage pain. Not everyone is specialized or trained in it. There's about 950,000 licensed physicians in the US right now, and only 4,000 or so are trained in pain medicine. So most of our pain medications are prescribed by ER doctors or primary care doctors. And those providers may not always have the time to appropriately evaluate those patients, and they're not always the most trained in addictions and dependence as well. So being able to keep an eye out for that is going to be really important. I'm going to try and run some more numbers by you. I know Dr. Shah threw a few out there, but I'm going to compare the US to global numbers. And if you've looked at this opioid problem recently, you'll see that they compare us to the rest of the world. We use over 90% of the world's opioids. And you can get different opinions from different people as to why this is happening. Some people say that we're more humane and we don't want our patients suffering. I've heard some people calling us a group of sissy wimps who can't tolerate any pain. Take it as you want, we're still giving more than we should. If you look at the European Union, there's about 500 million people compared to the 320 million people in the US. But they only had about 7,000 overdose deaths in 2016, whereas the US had about 35,000. So it's 5 times more overdose deaths in the US than there. And looking at these numbers, everyone has their opinion, and I found one from Stanford professor, Keith Humphreys. He said, the best way he can explain these numbers is that, maybe there's this cultural expectation on how fixable we believe life is. He said, America's still young, and, we believe life can be perfected, whereas other countries have kind of come to that idea that certain things will hurt and we can't always treat it, and they will get better with time. And those countries are only using opioid pain medications for things like cancer. And so we may end up following suit with them. In Europe, specialists are more commonly prescribing these opioid medications compared to primary care doctors here. And they are mainly prescribing it in a hospital setting, not an outpatient setting, and it's mainly for cancer patients, like I just said. I looked at Japan's data, and they didn't even have access to a lot of these pain medications until real recently. Oxycodone wasn't introduced till around 2003, and that was only for cancer patients. Tramadol wasn't even introduced till about 2010, so that's about 15 years after the US had it. And then some of those combination drugs like oxycodone with acetaminophen or hydrocodone with acetaminophen aren't even available there yet. But I mean, this epidemic isn't limited to the US. There's actually studies in Japan saying that by 2024, there's going to be an increase about 62% in demand for these opioid pain medications. So it's interesting to see that it's not just us, but we have the biggest issue going on right now. If you look at the states specifically with the lowest amount of opioid use, Hawaii is one of the lowest users in the US. And a lot of people believe that maybe the Asian influence, the alternative treatments like Dr. Abbott mentioned, yoga, meditation, Tai Chi, things like that may be more frequently used, along with using family and social support more than these pain medications. So what has the government done so far to kind of help us with this epidemic? Well, Dr. Shah and I had an opportunity to go to the Opioid Action Plan in September 2017, where the government also released the Opioid Prevention Task Force. And some of the three big things that they're trying to work on is preventing the further spread of the opioid crisis, promoting a recovery of people with opioid use disorder, and helping people who have overdosed and preventing further deaths. So that's pretty important. Another thing, like Dr. Shah mentioned, is the prescription monitoring program. Everybody since January who has a controlled substance license needs to be a part of that, needs to document that they're using that as well. So remember to look at that when your patient comes in asking for refills, document that you looked at it and nobody else has filled any pain medications besides yourself. And then there's also the creation of the Opioid Use Hotline, which you guys might see in your handouts as well. There's a number 1-833-2 find help. It seems like a whole lot of numbers. I actually counted it. There's like 12, so I was like, that looks like a bizarre phone number, but it works. I did call it to test it first. So what about these patients with opioid use disorders? How can we help them if they want to come off of these pain medications? Well, there's a few medications out there that are commonly used. Methadone and buprenorphine, these are both agonist medications. So they act at the same receptors as these pain medications do. And they've been shown to be pretty helpful. Methadone, we need to remember, can only be dispensed from a methadone clinic. So not every prescriber can give that to their patients. But buprenorphine, most providers can get a training for it. There's an 8-hour course that you do, you get a waiver. That was part of the Drug Abuse Treatment Act of 2000. So if you're interested in that, you look that up online. It's through SAMHSA and the American Academy of Addiction Psychiatry. They all have resources for that. So you can get trained for that. It's only 8 hours, and you can prescribe buprenorphine out of your clinic. Another one commonly used is naltrexone, and that's an antagonist medication. So it blocks that receptor. And that's one that comes in injectable form. People can come and get monthly injections of naltrexone. And that helps in decreasing cravings for these medications. Now, what about our patients who are high risk for overdose? What can we do for them? Well, we want to make sure that they're safe, so limiting the amount of the pain medication we give them, making sure that they lock them away so other people can't get it from them. Children, teenagers, things like that. There's a trend for mystery drug parties, so kids will take pills from their parents' pill cabinet and bring it, put in a bowl, and you grab a handful and you take them. So a lot of people are trying things like that, and we need to make sure that those meds are locked away. Another important thing, I'm going to have you guys help me pass some of these out. So how many of you have seen one of these before? Okay, so very few of you. Now, What this is inhaled naloxone. So this is an antidote for an opioid overdose. Now, understandably, you're not going to be prescribing this to the patient you're giving the opioids to. You're going to be giving it to the family. So you have them come in, you bring a loved one in, you bring a parent in, whoever they're using the substance around, you bring them in and educate them on how to use this. If you find an opioid user unconscious, spraying this into their nasal passage will give them some time. This has about 4 milligrams of naloxone in it. Gives you enough time to get them to a hospital. They may need several doses of this, but it'll help them get to the hospital in time at least. This does not require a prescription. Although a prescription will help and it'll emphasize the importance of it to your patient, but they can go to a pharmacy and buy one of these. And insurance will probably cover it more likely if you do give a prescription. About $100 to $200 depending on the formulation or who's making it. Co-pays are between $0 and $20. So anybody on a lot of pain medications or you're concerned about heroin use, make sure they have one of these at home. It'll definitely help them out. There's also different forms. There's an injectable form as well. This makes it a lot easier for people who aren't trained. Pretty much you just open it.
This treatment contains no needle or drug.
Okay.
To inject, place black end against outer thigh, then press firmly and hold in place for 5 seconds. 5, 4, 3, 2, 1. Injection complete.
So as you can see, very easy to use. You can give this to any family member, and if they find someone down who's an opioid user, it comes in really handy. You don't need to be too trained in that. So those are important options that I think we need to be aware of. I've had people say that giving these to our patients might make them more risky, but most of our patients are not intentionally overdosing. So just as we have someone with a peanut allergy, we're going to give them EpiPen. Very similarly, let's give them one of these as well. I'm going to kind of finish up by talking about resources in the community. I tried looking online to give you guys the most information I could. I apologize, I didn't find that much, but for pain management, Blessings Health System in Quincy has pain specialists there. So a lot of the injections that Dr. Abbott was talking about are available there. For psychiatric services with addictions, there's the Mental Health Center of Western Illinois. They have about 3 branches. Perfect. And then for substance use, there's Preferred Family Healthcare in Quincy. They have some resources, and then Transitions of Western Illinois as well. And then in Springfield, we have Gateway, Triangle Center, Wells Center, Rebound, and Racet Care. So those are some of the things to keep in mind if you have patients that need help with their opioid use disorder. Referring them is going to be important. I know psychiatrists aren't that frequently found, but you guys have MCHWI here, or MHCWI, and so that's a great resource for you guys. But thank you all for coming today, and I appreciate you guys taking the time to listen. I'll pass some of this stuff around as well if you guys want to take a look at that.
So with that, what questions do folks have, either here in the room or at our distant sites? I'm going to unmute our distant sites so that you guys have the opportunity to ask questions. But you can also ask questions through the chat function.
We have discussed gabapentin as an option for pain, and we've been informed that people are now using it and they're trying to get control. Do you have any information regarding that?
So let's move closer to the microphone and restate the question so that the people at the distance can benefit as well.
Okay, so the question asked was about gabapentin having a risk for abuse and whether this is going to be controlled moving henceforth. And that's an excellent question. The CDC in its guidelines did state that these anticonvulsants, medications for seizures, do have a risk for abuse. And that is something we're seeing now. I'm not too sure about the control of this medication. As far as I'm aware, it still could be prescribed by physicians without needing a controlled substance license. So I'm not entirely sure about that. Dr. Wolf, do you know anything different? But that's a great question. Thanks.
I think there was a question over here.
Yes. Could you elaborate and maybe explain a little bit more of perhaps why we have so very few Suboxone prescribers?
So I think, sorry. So the question was, why don't we have many Suboxone prescribers? So initially, Suboxone prescribing was only for people who were addictions trained and had a few other certifications. But now they're actually making it more available. And instead of going through a full residency and a fellowship for addictions, other prescribers can use it as well. And that 8-hour waiver course is what is commonly done. We've all actually had that training as well. Family medicine in Springfield has done that as well. I'm not sure if there's any other limitations at the moment and we can get that or not.
Well, there are some, any active prescriber, so physicians can get buprenorphine data waivered, nurse practitioners, PAs. So there's a process for everyone to do it. I think some of the limitations that prevent people from getting the data waiver is, there's some fear associated with when you initiate Suboxone. So there's kind of two elements to Suboxone, but if you're going to be initiating it in your outpatient practice, you need to have people start to go into withdrawal in your clinic, which scares a lot of people of, I'm gonna have someone sitting in the waiting room going, in active withdrawal. And so that can be a little bit intimidating. Now, sometimes Suboxone can be started on an inpatient setting when someone goes in, or a rehab setting, like at Gateway or the Wellness Center. And then you need someone to manage it, kind of the continuation, which that's a little easier from a prescriber's perspective. There's also concerns about, I'm not a behavioral health specialist. I mean, I am, but if I'm a primary care doc, I'm not a behavioral health specialist. And so people are using this because they have some behavioral health condition that needs to be treated. And so what do I do? And I don't feel equipped to do it. So there's a lot of kind of those barriers, those comfort zone barriers that preclude a lot of people from getting their, from either getting data waivered or utilizing their data waiver. There's actually a brochure over here on the counter. And those of you who are at the remote sites, we can email you the information. We've started a project in conjunction with the Illinois Hospital Association to help prescribers in central and downstate primarily, but we have people from Chicago participating. We have a team of experts who are helping people get more comfortable utilizing buprenorphine and starting a Suboxone clinic in their own practice. And so we have some technical assistance from a provider's perspective, from the behavioral health perspective, from the just kind of administrative perspective of how do you bill for this stuff? How do you train your nurse to manage someone who's having early symptoms of withdrawal in the waiting room? And how do you train the person answering the phone to, so all of those kind of things are what we're trying to address through this, what's called an ECHO project. So hopefully we'll get more people utilizing their data waiver.
Looks like Angie Cardinal submitted a question that Dr. Abbott might be answer.
So where can we find more data and research regarding alternatives for pain management? Best resources for what works for different conditions based on the research.
Thank you, Angie, for your question. So most of my data came from the CDC guidelines, which has a short paragraph about the medications that can be used as alternatives. Some more information that I found was from the ACP. They put out an article in 2017, and that one was actually very helpful. It separated the medications for alternatives into what can be used for acute and chronic treatment, and that could be a good resource. I don't know if there's any way that we could send that information via Zoom, so that.
I don't know that we can send it via Zoom,
Okay.
but we should have a list of all the participants. If
And the
everyone
reference.
signed in at all of the different sites, and we can send out some resources.
That'll come from Kitty, Kath and Jewel.
Yes.
Great, so we could provide some more information with regards to that.
Other questions?
I have a question. I'm not really sure that, in my mind, it connects to kind of what y'all are talking about, but obviously, to address the crisis is a team effort with the physicians prescribing the behavioral know-how, recognizing the signs and symptoms, connecting them to resources, the hospitals. So, what I'm wondering is what role is the pharmaceutical companies that are producing these opiate medications, are they actively involved in this process? I mean, just looking at it from a business standpoint, from their point, you know, if you're in a business to make money, to prescribe, to have these opioid medications available, you know, Oxycontin or whatever, are the pharmaceutical companies on board? I guess it's my question. Maybe you can't answer that question, but to me, I see them also as a player, but maybe it's not relevant to the conversation. But
So the question had to do with the pharmaceutical companies and what's their role in trying to address the opioid epidemic. Are they on board with helping to address this, since they were part of what created the problem that we are encountering today? I don't know if any of you have any specific information on that. You know, what I can tell you is not anything official. It's from conversations I've had with people at SAMHSA and primarily SAMHSA. And it's, you know, there is some reluctance kind of on a national level for pharmaceutical companies to jump into this conversation one way. So they're largely remaining quiet on it.
Like back in the 1990s when like Prescribing Pharmaceuticals was advertising on TV, hey, opioids are fine, there's no addiction potential. Shortly after, they were buying like hundreds of millions of dollars. I'm not sure what their role is in terms of advocating now. What their role is.
as a mental health provider, we have found the website, our psychiatrist really used this website that was available inquiry with looking at patients that he's prescribing for to see about their use of.
Yeah, the PMP website?
Yes.
Great, great. A corollary, I know it's not exactly what you asked, but I think it's a resource that hopefully we can get available to all of the sites represented here. So, you know, there's a lot of grants, such as the grant that's funding these presentations right now to really try to address this opioid epidemic. And one of the grants that's out there that the University of Illinois in Chicago has is what they're calling academic detailing. So it's a counterpart to what pharmaceutical companies actually did in the 90s to really get physicians out there prescribing opioids. It's a group of kind of clinical experts, physicians, pharmacists, primarily working collaboratively, coming out to practices and meeting with the physicians and really talking through their specific prescribing patterns, giving them strategies, you know, looking at using some of the PMP data on individual prescribing practices and saying, you know, in this cluster of patients, what's going on? Why are you prescribing such high MMEs, morphine milliequivalents? Why are you prescribing opioids with muscle relaxants with benzos, which we know is puts someone at significant risk of overdose. And so talking through, trying to understand who the patients are that maybe there could be an intervention to reduce their risks for addiction or get them on a safer medication regimen, whatever. So, I mean, it's not exactly what you asked, but it's a counterpoint to what the pharmaceutical companies have done.
One of the other things I wanted to add is we got little computers in our pocket all day long, so cell phones are great resources. That one handout there has the CDC's opioid prescribing app. And so if you download that, that has a calculator built in it. So it makes it very easy. And the whole guideline can actually be found in that app. So it's a good resource.
And I was telling these guys, I mean, you know, they grew up in an era, medically grew up in an era when there were all of the, you know, Narcan, Vicodin, and all those things. Those meds didn't exist when I was a resident in his medical training. It was, there was morphine, there was short-acting morphine, there was long, and so you didn't really need to think in morphine milli equivalents. And so I think that's one of the challenge a lot of kind of prescribers of my age struggle with is, so how potent is this one versus this one versus this one? And so that's where that calculator can really come in handy when you're in the hospital, you've got a lot of patients to see, or in a busy clinic trying to churn through your patients and still want to be safe in your prescribing of opioids. So I think a lot of us have, over time, overprescribed, not understanding that certain formulations were much more potent than we really realized. Any other questions?
I just want to make sure everyone knows that this was recorded today and it'll be available online very soon. Kitty was hoping she might even get it up today.
Right.
And as Dr. Wolf mentioned, there'll be 5 more of these sessions over the next month and a half-ish before the June. There'll be in-person sessions. Most of them are similar setup to today, but one of them will be a half-day session in Springfield. There'll be maybe some overlap in material at some of them, but there's also other things covered than what we covered today.
Right.
So you all are welcome to attend any of those sessions in person. If there are some sites that are doing this remotely, but they're mostly in Southern Illinois, so I don't know if we'll have any local sites to do it, to live stream it, but you can also access it online afterwards. All of the CEUs associated with these are free because of the grant. So take advantage of that. And there's the website also, we have a website under Department of Psychiatry at SIU that has lots of resources, the ones discussed today, as well as many more on this topic.
And so everyone who has signed it, there's a question, will we explain how to obtain CME? So everyone today who has signed in should be getting a link, but no.
You have it in front of you.
Okay, the remote sites?
Oh, I'm sorry, CMEs, sorry. We have to do the pre and post test. As long as you turn that in, then CMEs will come after.
So at the remote sites, they have the pre and post test,
I believe
or
so.
they're going to be emailed out?
I believe they have, but let me check.
Okay, so do you have the pre and post tests at the remote sites? Okay, so you will receive an email with a link to get your CME credit. You will need to fill out that pre and post test that you have at your sites, and then when you'll get an email link that will allow you to download a certificate for the CME or the CME credit. The other thing is the recorded sessions. When you get this link that's going to be emailed to you, if you go through that website, so it's the SIU School of Medicine Continuing Professional Development, or CME website, if you go through that website and register to watch the recorded sessions, if you can't participate either through Zoom or live at the other sessions, there's a way you can get the CME for those as well, as long as you register through the official CME website on the School of Medicine. We're also going to make these available just on the SIU Psychiatry website, the videos, but you can't get CME just for watching it through there. You have to watch it through the CME link. Other questions? All right, thank you all.
Thank you.
Thank you.